Welcome, everyone, wherever you are in Europe and in the world. We are delighted to have you join us on this webinar today. My name is Esther Mary Darcy. I am the chair of the Europe region of World Physiotherapy, and this is our World Physiotherapy Day celebration webinar, even though it's coming to a few days earlier than the 8th of September, which marks the day on which our global organization of professional organizations was founded back in 1951. The theme of this year's World Physiotherapy Day is low back pain, and the Europe region is delighted to join with the European Pain Federation in hosting this webinar on the role of physiotherapy in low back pain. While the global burden of disease study showed that low back pain is the leading cause of years lived with disability, the positive news is that low back pain responds to physiotherapy, and going on to an emphasis on self-management. Two recently research studies both in the Lancet demonstrate the value of physiotherapy, one involving a comprehensive mind-body physiotherapy approach in terms of reducing both pain and cost. And the second one brings to mind an old Latin phrase, which I really like, which is solvitur ambulando, which means it is solved by walking or moving. And now there is scientific evidence to show that. This second study showed that a combined health coaching physiotherapy with a progressive walking program actually significantly reduced the risk of recurrence. So today, we want to share the role and the evidence with you, and we're very fortunate to be joined by a panel of physiotherapist experts in low back pain, including members of our musculoskeletal disorders advisory group in the Europe region. Gay Pearce-Murphy will chair the session, and Professor Kieran O'Sullivan from Ireland and Professor Felix Khan from Turkey will talk about the myths and the evidence. And we're equally delighted to be joined by our colleague, Professor Brona Fullen, from the European Pain Federation and its immediate past president, who will speak about the resources that EFIC, the European Pain Federation, has produced for the evidence-based management of low back pain. Professor Fulham will also speak to you about the federation. And Miguel Perez, a physiotherapist from the Europe Region Secretariat, will speak to you a little bit about the Europe region of World Physiotherapy. So I hope that you will find this webinar of benefit, and thank you again for joining us. And I will now hand you over to the chair, Gay Pearce-Murphy. Thank you.
Thank you very much, Esther Mary. And I'd like to introduce Miguel Perez Navarro, who is a physiotherapist graduated from the University of Valencia and works for the European region of World Physiotherapy as the Communications and Operations Officer. Among his tasks are the coordination of the European region working groups, attending and participating in events and conferences on behalf of the association, and internal and external communications. Miguel.
Thank you very much, Gay, for this introduction. Okay. Hello, everybody. My name is Miguel Perez Navarro. I'm a physiotherapist working as Communication and Operations Officer for the Europe region of World Physiotherapy. And I'm going to make a brief introduction of what is the Europe region and its musculoskeletal disorders satellite working group. Founded in 1951, World Physiotherapy operates as a non-profit organization. It represents more than 600,000 physiotherapists worldwide through its 128 member organizations. World Physiotherapy has 5 regions, each composed of member organizations in that geographical area. The South America region, the Africa region, North America Caribbean region, Asia Western Pacific region, and the Europe region. The Europe region is a non-profit, non-governmental organization that represents the physiotherapy profession at European level. Founded in 1998, it has a membership of 38 physiotherapy associations, one from each of the European countries, representing approximately 200,000 physiotherapists in Europe. This makes the Europe region the largest region of World Physiotherapy. The strategic objectives of the Europe region are demonstrate the value and impact of physiotherapy, the recognition of physiotherapists by the national authority as autonomous professionals in the national healthcare system, promote excellence in physiotherapy education, practice, and research, and to be influential in relevant policy development at EU and national level. To summarize briefly how the working groups of the Euro region works, every 2 years, the general meeting of the region is held. Representatives of its member organizations need to meet to approve budgets, documents produced or updated during the last 2 years, discuss current issues in European physiotherapy, and vote for half of the members of the executive committee. After the general meeting, the executive committee meets to select the physiotherapists who will be part of the working groups for the next 2 years from the nominations sent by the member organizations. Currently, the Euro region has 3 permanent working groups: the Advocacy and EU, Education and Research, and Professional Practice, 2 thematic working groups, Mental Health and Cancer, and 1 satellite working group on musculoskeletal disorders. These working groups will, over the next 2 years, be responsible for developing position statements, information papers, communication materials, carry out surveys, and produce reports on the situation of physiotherapy on certain topics. These are used by the Euro region and member organizations to advocate for the profession. The members of the working groups represent the Euro region, attending and participating in events and conferences as delegated by the executive committee of the region. They arrange webinars to different target groups that are afterwards uploaded to the YouTube channel, collaborate with EU institutions, and collaborate with stakeholders and other healthcare associations. Since the creation of the MSD Satellite Working Group in 2020, its members have collaborated with EU OSA, the European Agency for Safety and Health at Work, by participating in the last 2 editions of its Healthy Workplaces campaign. They also collaborate with the European Pain Federation EFIC by contributing their knowledge and experience in their On the Move campaign and in other possible projects such as this joint webinar. In addition, the MSD's Satellite Working Group, influenced by the EU OSA campaign, has developed over the last 2 years several initiatives focusing on MSDs at work: a position paper on the role of physiotherapy in MSDs in the age of remote work, a booklet with an illustrated version on the management of MSDs at work, and is running a social media campaign called Move at Work, where every Monday a tip is posted to encourage more movement in the workplace and reduce MSDs at work in workplaces. Also, influenced by the USA campaign, the MSD Satellite Working Group held a joint webinar on cost-effective options to tackle MSDs in the telework era. You have access to all this information and materials of the MSD Satellite Working Group on the Europe region's website, which you can access via this QR code. And well, this was all from me. Thank you very much for your attention. You have my email address here in case you want to contact me, and the social networks of the Euro region, so you can follow them if you want to be updated on what we do. Thank you very much.
Thank you, Miguel. Now, I'd like to introduce Professor Brona Fullen. So Brona is the past president of the Irish Pain Society, and also from 2020 to 2023, she held the position of president of the European Pain Federation EFIC. She is the first chartered physiotherapist and the first female to be elected to this position in the organization's history. But currently, her research focuses on pain management programs where she is leveraging 2D and 3D virtual reality technology to help people manage their pain. She is also integrating virtual reality technology into her students' physiotherapy programs to augment the students' clinical reasoning skills around pain. Today, Brona is going to give us, first of all, an introduction about EFIC, and later on, we will talk to her again about the resources which EFIC bring to support evidence-based management in low back pain. So, thank you, Brona.
Thank you, Gay. Welcome, everybody. On behalf of the European Pain Federation, I'm absolutely delighted to be collaborating with Europe region of World Physiotherapy to celebrate our professional organisations. So as Gay mentioned, in my next presentation, I'll be discussing EFIC in detail, but just to give you an overview of who we are as an organisation. We are a multidisciplinary professional organisation in the field of pain research and pain medicine. And we represent the 38 European chapters of the International Association for the Study of Pain. So this currently we would have more than 20,000 researchers in basic, translational and clinical science, as well as doctors, physiotherapists, nurses and psychologists who work managing people living with persistent pain, but of course are managing people with acute pain and hopefully preventing the development of chronic pain. As an organisation, I suppose our global aims are to advance research, education and the clinical management of pain, serving as the authoritative science-based resource on issues related to pain and its treatment in Europe. And you'll hear more about this later. And over the 3-year terms of my presidency, and in fact, since I joined the board of the European Pain Federation, I was very keen to reach out to other European level organisations, to collaborate and work together, because certainly pain, as we all know, is one of the core reasons people attend for physiotherapy. So, it was a very easy link to make with Europe region of World Physiotherapy. And I'd just like to publicly thank Esther Mary Darcy and the Europe region of World Physiotherapy, for working so well with us at EFIC and building strong links, which I know are continuing to develop and will into the future. So for the moment, thank you very much from me.
Thanks very much, Brona. So now we have our first speaker this morning, who is Professor Kieran O'Sullivan. Kieran is the head of physiotherapy at the University of Limerick in Ireland. His primary area of research is low back pain. And today, Kieran is going to talk about the myths of low back pain. So now, Kieran.
Lovely. Thank you very much, Kate. And thanks to Europe region of World Physio for involving me in this campaign. So Feliz and I, over the next 15 minutes or so, are going to talk about some of the myths of low back pain. First of all, before I suppose, Feliz and I speak, I'd like to acknowledge that this is not the work of just myself or anybody else. I was one of the people involved from World Physiotherapy in the development of this campaign, and I'd like to acknowledge the work of others.
Sorry, Kieran. I think you're not displaying the presentation mode.
Oh,
for
sorry.
the audience.
Let me just, sorry, I'll stop there again. Apologies. Let me share again.
It's okay.
I'll try this one. Is that better?
Yes, perfect.
Oh,
Thank you.
apologies. So so just acknowledging the contribution of others. And what we came up with in summary, looking at the evidence and I guess some parallel campaigns that have been done before, was a series of 12 myths that we feel the evidence suggests are not particularly evidence-based or useful. So in other words, there might be myths out there that are inaccurate but might be relatively harmless. However, in these 12, there is at least a suggestion that some of these myths are unhelpful and are things that we could target with a view to changing knowledge, but especially beliefs, attitudes, and practices amongst people with persistent back pain, as well as family members, members of the community, and so on. So if I go through those campaigns, and we'll talk about them, in a little bit of detail in the questions and answers, if people have a desire for that. A lot of them are around the structural model of pain, which is what many of us would have been, I suppose, trained in many years ago. So the first one was that my back hurts a lot, so I must have seriously damaged it. And while, of course, specific injuries and pathologies can be a part of some pain, and especially the onset of pain, what we know at this stage is that people can have tremendous back pain, but have thankfully relatively little evidence of serious damage. They might have some normal age-related changes, but the chance of somebody with back pain having serious damage in their spine is relatively low, and a qualified physiotherapist or other healthcare professional is usually in a good position to tell you if there's significant damage or not. Because of that, it's rare that scans or x-rays are needed in order to kind of determine what best practice management should look like. So again, in contrast, years ago, we might have thought that a good treatment for back pain depends on a particular type of x-ray or scan so we could get a good picture of the spine, but that doesn't look like it's the case anymore. And again, on that same theme of the structural nature of back pain, there was a concern that people will wear out their back and they will inevitably end up with back pain if they do demanding tasks such as bending and lifting. Whereas again, in the short term, for sure, people, including myself, can get sore and stiff from doing unaccustomed bending and lifting. There's no evidence that that's dangerous in the long term. Quite understandably, painkillers have had a place in the management of back pain, or at least pain medications. And unfortunately, that has included testing some medications with significant side effects. And so we're increasingly aware of the risks of opioids and other medications being trialed with significant side effects. And at least if these were having a big effect on pain, we might justify them. But what the evidence tells us is these strong pain medications have a modest effect on pain, yet significant downsides. From a manual therapy point of view, it's probably pretty common that people who have seen a physiotherapist or a chiropractor and had some manipulation performed, it's quite common that they associate the reduction of pain in the short term with something being put back into place. Whereas what we know at this stage is that even if you have an adjustment or a manipulation done to your back and you feel better, that's great in the short term, but it's probably about other things rather than something being realigned. As a middle-aged man like myself, I'm very conscious of, things can start to creak and all that as we get to being a little bit older. But actually getting older in itself does not inevitably mean we're going to have back pain. In fact, if you look at the biggest times of increases in back pain, there's specific periods like adolescence where we go from very little back pain to lots. But it's not inevitable as we get older. Going back to, I guess, a more positive message, one of the things that the public seem to have understood is this next myth. Previously, there would have been a big belief amongst the public that staying in bed and resting was really important before you return to work or engage with rehabilitation. Whereas thankfully, the message of movement being important is thankfully getting out there. And I guess it's a bit like, for me, that emphasis of switching from rest to movement is a little bit like what we've seen with GPs prescribing antibiotics for sore throats, which aren't evidence-based, and it takes a while for those messages to get out there, but they can. Moving on, obviously we're advocates of exercise, but it is, of course, possible and common that when people with back pain start to exercise, that it might be painful. And while we're not suggesting that people must suffer through their rehabilitation or we must inflict terrible pain, it is quite possible that some of the exercises we prescribe might be uncomfortable and painful at the start. And obviously we'd like that to be as comfortable and acceptable to people as possible, but that pain is not reflective of harm. It probably reflects the fact that your body hasn't moved in a long time. It's quite sensitive to movement. And so again, helping people understand that in the context of persistent back pain, things can hurt and that's not necessarily dangerous or harmful. Going on to the last few, I did my PhD on sitting posture and back pain. And as soon as I told people that, they almost instinctively felt that they had to sit up straight like a good boy or girl, because it's a cultural kind of belief out there that sitting posture is causative. If you sit particularly slouched, you are going to get back pain. Whereas what the evidence tells us is people who sit slouched, yes, lots of them get back pain, but people who sit upright also get back pain. People who sit over to one side get back pain because back pain is a common human experience. There is no one bad posture causing back pain, and there are other more important things we can focus on. Then the final few, and Felice is going to talk about different forms of exercises in a while. There's been a lot of focus, especially I suppose going back for the last 20 or 30 years, on one particular form of exercise being important, and that was these exercises called core exercises. So specifically focused on the back and the tummy. And I guess to acknowledge, first of all, those exercises, like any exercise, can help people with back pain, but there's nothing specifically more effective about them. So from our point of view, the good news is that all exercises seem to have a beneficial effect on back pain, but we should probably be more focused on preference, cost, and access. So do they like it? Can they afford it? Is it available close to their home? As opposed to there being one best exercise. Because then of the evidence that physiotherapy using these approaches can have a beneficial effect on back pain, we're now happy that there is, I suppose, a great potential for us to help people with back pain. And that's a good alternative because the evidence that surgery or injections can help back pain is modest at best. And we have, again, some greater risks with some of those interventions. So it's rare. Surgery injections will still have a role, but it's rare that they are necessary to solve back pain in particular. And I guess finally, on that idea that when your pain is bad, it must be damaged. Again, if people go from having mild pain to moderate pain to severe pain, it isn't that their spine is getting much more damaged. It's a mix of all these factors across lifestyle, psychological factors, and so on. So as I said, when we're going to talk about those two approaches, I'm going to focus just very briefly on how we might look at the education self-management, which would align with those myths. And then Felice is going to talk about some clinical interventions. So in terms of education and self-management, I think we have a role in challenging those structural myths. So explaining, as I've touched on, why scans and x-rays might be useful sometimes, but that's pretty rare. Why medication, injections, and surgery, their effectiveness is modest. There are some risks. We should really delay engaging in some of those interventions until they're really necessary. Because again, in terms of the concept of back pain, it is not primarily a structural problem. It is a biopsychosocial problem. We're treating humans, not scans. On the frailty myths, lots of those ones that we looked at are based on the idea that the spine, the lumbar spine, is particularly frail, that if you sit a certain way or bend a certain way or too much, things can go out of place and wear and become very brittle. Even the concept of aging is around crumbling or a degenerative kind of a process happening in the back, and that because of pain, we must rest. And again, while these beliefs are common and understandable to some extent based on what we used to believe, over time, I feel we really have to challenge that message that the body and the spine is that frail. And again, not by forcing people, but by gradually building resilience, so building up confidence. And we can't just talk people into being more confident. In other words, if somebody's afraid of bending, we can't just tell them, just bend, you'll be fine. We have to practice with them, grade that exposure to bending, build up their physical conditioning, but also their psychological readiness for that. So building resilience rather than fear. And then finally, I suppose, and this is where we come to this scope of practice considerations around where are we going and what can physios do within these other factors. I think physios can have a very good role in facilitating holistic self-management support for these other factors that are really important in pain. That can be sleep, stress, worries, activity, diet. But critically, and again, we can come back to that in the questions, we don't want that to come from a preachy kind of blaming the patient for their predicament perspective. We want to try and support them and find solutions that will work for them. And so moving forward, what kind of things can we do? So in the short term, facilitators of addressing this myths, the good thing is we have the evidence that some of our interventions are effective, some other interventions are ineffective and have cost and harm. So the evidence is facilitating that, but evidence alone will not be enough. I think campaigns like this current one are important, and as well as some of the stuff that Brona will talk about in terms of educational materials are important. We need to reach out to people to change these myths in different settings and formats and have different messengers. So not just the clinicians, but the patients, and again, linking in with patient advocacy groups and employers and so on. But there are some challenges. Societally, there is a dominant biomedical outlook, and that means wider society, but also patients, employers, healthcare professionals. It reflects the way we've all been brought up to think about pain, and that won't change overnight. We probably need to keep looking at how professions are training, including physio, but actually a whole series of different professions. And part of the challenge there will be making sure that each profession is comfortable with their professional identity. So, for example, when people come to see me as a physio with back pain, they're still almost automatically getting ready to take off their clothes because they're already thinking of the traditional stuff we do, which we will still do around examination of the spine, but they're probably not as ready for a detailed discussion around sleep and stress and work-life balance and so on. And so each profession, and I think physio is very well positioned for this, needs to think about where our scope of practice for back pain lies. We will still have a big emphasis on history taking, clinical examination, hands-on palpation, identification of barriers to recovery, but it might over time continue to evolve. And I guess beyond the profession, there's real challenges in funding models. I think, for example, if I go back to the top, the evidence is there for us having a really strong role, but funding models don't support that for either prevention or treatment. So, for example, for prevention of back pain in my own organization and many, the focus is on the height of my disc, the position of my laptop, but not about other factors that have a greater evidence base. And in terms of treatment, it is probably still the case that in most countries, it is easier to get funding for an injection or an arthroscopy or some other interventions that have less of an evidence base than supported supervised rehabilitation, such as a physiotherapist can provide. There are some links, I suppose, providing resources for this campaign and related to that. And that's all I've got. Thank you very much.
Thank you very much, Kieran. Just to remind everybody that we'll be taking the questions at the end. And if you could type your questions into the questions and answer box, that's where we'll be getting them and responding to them. And now I'd like to move on to Professor Filiz Khan. And Filiz is from the Hacettepe University in Ankara in Turkey. She is a lecturer there in the Faculty of Musculoskeletal and Orthopedic Physical Therapy and Rehabilitation. She's also a member of the Executive Committee of the Turkish Association, where she holds the International Affairs Chair. Filiz is also a member of the Education and Research Matters Group of this organization. Her personal research is in the area of orthopedic rehabilitation, rehabilitation of the elderly, sports injuries, and manipulation therapy. So today, Filiz is going to continue on the discussion about physiotherapy in low back pain. Thank you, Filiz.
Thank you, Dee. First of all, I would like to congratulate the World Physiotherapy Day, all my colleagues all over the world. And also, I would like to give my thankfulness to World Physiotherapy Europe region to include me this webinar. Okay, Kieran has given such a valuable, important key points about education and self-management. And then what we could do in the clinics as a physiotherapist. Actually, the aim of physiotherapy in patients with low back pain to relieve pain or promote analgesia, to create controlled forces to the articulations or also the soft tissues, to promote non-destructive movements, and to increase neuromuscular efficiency because these patients has got some deficits in their proprioception or neuromuscular responses, and also to provide biomechanical counseling. So regarding to some guidelines about management of low back pain, we can see various type of interventions in physiotherapy, like exercise therapy, manual therapy, specific exercises, motor control training, education, back school programs, behavioral treatment, electrotherapy, water therapy, traction, and also multimodal treatment. But the results came from some meta-analysis and also the systematic reviews, especially focused exercises. We have to focus on especially stabilization and motor control exercises, Pilates, resistance training, and aerobic exercises. I'm so sorry, I have to put a plug. I'm so sorry.
Now, I think Phyllis will be back in a minute.
Okay. Sorry, I came.
Here she is now.
I'm very sorry.
No problem. Take your time there.
I just realized. Okay. So especially these kind of exercises has been found most effective treatment options. Then, sorry, therapeutic exercises in low back pain covered many well-known exercise strategies, especially for rehabilitating the functional demands and activity, enhancing cardiovascular fitness, improving flexibility, and then also biomechanical efficiency, assisting pain relief through several local or general physiological effects. When we are planning as an exercise program, as a physio, we have to mostly focus on lumbar multifidus and transversus abdominis, because all those muscles are the key muscles of the rehabilitation of the back. Actually, especially in the specific exercise program, core exercising or also the stabilization exercising, we are using these exercises. But in addition to exercising trunk muscles, we have to take into consideration of the movement of the upper extremity, because the movement of the upper extremity activates the transversus abdominis muscle contraction. That's why we have to think about also these helpful strategies. Core stability exercises, you know very well these exercises, the physiotherapists, because most national and international guidelines recommend these exercises. And then core stability exercises has strong evidence in pain and disability. And then those exercises is most beneficial exercises, especially for segmental stability. The current literature also mentioning about the stabilization exercise tends to improve balance, especially the patients suffering from low back pain, elderly patients suffering from low back pain. So you can see some exercises, core stability exercises in my clinic. Then what about the other exercises? Actually, Pilates is one of the effective exercises because the study results state that Pilates exercises has tends to significant improvements in pain relief and functional enhancement in the short term, but not more effective than the other exercises, especially in intermediate term. That's why we can use Pilates for pain and function, especially in the short term, but other exercises are more effective in intermediate term. That's why, dependent upon the term, you can use or you can plan your exercise program. Regarding the guidelines, the water-based therapy or aqua therapy also very valuable because aqua therapy or water-based exercises effective in decreasing pain, improved disability, improved quality of life, improved lumbar range of motion, and then it's recommended these kind of exercises more than land-based exercises, because land-based exercises may give more loading and more forces for the vertebral column and also the soft tissue. That's why, especially in the initial term or first term of the exercise program, you can prefer these kind of exercises in your program. We can also use endurance exercises, resistance training, progressive walking, cycling, and also deviated treadmill ambulation. But when we are using treadmill, we have to think about that in every steps, especially in the heel strike of the gait, you may have, the patient may have anti-gravitational stress coming from the ground, especially the ground is very not soft ground. So that's why deviated treadmill ambulation can be preferable. What about the running or jogging? Because sometimes the patients think about that running or jogging program also will be helpful for their rehabilitation. But running has been found to create increased compressive loads on the joints of the lumbar spine. So that's why, especially first term and then intermediate term, the physios should not recommend the running program for their patients. Some study results state that there's a link between dysfunction in the local muscle and then back pain, and then these patients have proprioceptive devices. These results came from the studies. It raised up the importance of the proprioceptive training for those patients. We wanted to determine the effects of proprioceptive exercises on posterior pelvic tilt strength and proprioception in chronic low back pain patients in our clinics. And then we saw that both stabilization exercises were effective, but additional proprioception exercises has given beneficial effects, especially for proprioception of those patients. So that's why we also giving motor control or motor learning program for our patients, because motor learning program restore the coordination, postural control or trunk control, movement control, capacity of the trunk muscle. And by this opportunity, the person controls their movement, posture, and also the muscle activation. If we don't consider the neuroplasticity of the nervous system in patients, particularly in chronic low back patients, we would not be so successful in our treatment program. That's why motor learning program is very important. In the low-term learning program, we are using appropriate facilitation strategy with giving extra proprioceptive input, giving awareness in cognition, facilitation of the muscle co-activation, automatic reflex recruitment, and also giving some tactile and visual feedback. Then we will be successful to control all body and trunk muscles, and also the coordinated movement in central nervous system and also the subcortical system. That's why motor learning model currently is compromising and also preferable intervention in our program. What about the manual therapy? Actually, as a physio, we are using manual therapy many times, but sometimes you don't know it has evidence scientifically. So some systematic reviews and meta-analyses concluded that manipulation and mobilization have moderate quality evidence in pain relief and disability. Also, myofascial release and fascial therapy has significant effect on reducing back disability, but not helpful for improving lumbar range of motion or improving quality of life. But it can be considered myofascial release or fascial therapy may be an effective adjunct therapy. All those knowledge and then scientific reports takes us, we have to use multimodal programs in the rehabilitation program of chronic low back pain patients or low back pain patients. That's why we have lots of tools as a physio in our hands, especially exercise is very strong tool. We have to take care of the patients, especially inspecting their exercise program and giving some kind of recommendation during the exercise. And as Kieran mentioned about be a mentor for those patients during exercise. Thank you very much for your attention.
Thank you very much, Phyllis. Very interesting presentations from both yourself and Kieran. We're going to move on and we're coming back to Brona. So Brona, you're going to talk to us about the resources which EFIC have. So I'll leave it up to you now. Thank you.
Thanks very much, Kay. So I would like to spend the next, I suppose, 15 minutes outlining resources that EFIC have to support clinicians and researchers in the field of pain science. But for today's presentation, obviously, I'll have more of a physiotherapy focus. So as I mentioned earlier, EFIC serves as the authoritative science-based resource on issues relating to pain and its treatment across Europe. Within the organisation, physiotherapists are the second largest group. And of course, we're always, I'll put a plug in here, we're always looking for volunteers to support and disseminate our activities. And I'll have some contact details at the end of the presentation if you'd like to get involved more with our work. So as Gay mentioned, I was the first female and the first chartered physiotherapist elected president of the European Pain Federation's executive board. It's a 6-panel board. It is multidisciplinary now. I represent a physiotherapist and Dr. Joanne O'Brien-Kelly represents nursing. And along with our medical colleagues, I suppose we drive the organisation along with our committees and executive office staff. So EFIC's activities, I suppose, map across 3 core pillars: education, research and advocacy. In education, we have developed curricula and offer examinations, diploma examinations in across the different disciplines. We run pain schools and we have e-learning platform. And I'll talk a little bit more in detail about these in a moment. In terms of research, we are active collaborators on research projects. We disseminate grants and prizes. And importantly, we develop guidelines and task forces with expert colleagues on particularly relevant topics. And then most importantly, of course, not forgetting advocacy, raising awareness on pain treatment and management plans, and campaigning, of course, to improve policies and research funding for pain, which will all hopefully, improve patient care and reduce the impact of pain on patients' lives. So in terms of our education activities, education, I suppose, is one of the most established and largest activity that we have. And our activities are both virtual and in person. Our suite of in-person activities include fellowships, we run pain schools, we've developed curricula, we offer refresher courses at our biennial EFIC Congress, and we also have run the diploma examinations, and I'll outline those in a moment. And whilst it was always on EFIC's horizon to develop virtual education, I suppose, like a lot of things, the pandemic really accelerated our plans. So with all our in-person activities cancelled, we pivoted quickly into the digital space and formed the EFIC Academy. So all our educational activities at EFIC map to our core curricula, and these have been developed for pain physiotherapy, pain medicine, pain nursing, and pain psychology. And the purpose of the curricula, I suppose, is to articulate the scope of practice required by healthcare professionals that's necessary for effective quality patient care. The curricula outline the breadth and the depth of knowledge, the range of skills, and the professional behaviours required for effective pain management. I suppose it also provides consistency of standards and outcomes, across different countries in Europe through the establishment of a benchmark of standard competencies. The curricula are updated every 5 years in line with best educational practice. And the second edition of the core curriculum for the European Diploma in Pain Physiotherapy was published in September 2023. I'm very grateful to my physiotherapy colleagues on the EFIC Physiotherapy Working Group led by Professor Harriet Whitting, and also again to Europe Region World Physiotherapy, who collaborated on the development of this updated curriculum. So the curriculum has 4 sections: pain science, pain assessment, pain management, and pain in specific populations. EFIC has also developed an undergraduate curriculum for physiotherapy, and the genesis of this came from an Erasmus grant that I was awarded, and again worked closely with Professor Harriet Whitting and other European colleagues, the Upscale project. So the undergraduate curriculum was published in 2023 and was endorsed by the European Network of Physiotherapists in Higher Education, or ENFI. We now have established a working group within ENFI for physiotherapists teaching pain and pain science and management to physiotherapy students. And through this working group, we hope to disseminate, or we are disseminating and hopefully embedding this curriculum across physiotherapy programs in Europe. So the curriculum can be for self-development and learning, but it can also be used, physiotherapists can also use it to test their knowledge by sitting the EFIC Diploma in Pain Physiotherapy. So this is a 3-part examination. Part 1 is held in the spring, it's held online, and it's a multiple choice examination. Parts 2 and 3 are held in person in Leuven in the autumn of each year. This includes a practical exam and a viva examination where there's a discussion around a submitted case study. So far, 30 physiotherapists have been awarded the diploma in pain physiotherapy. So if this is something you're interested in, lots of information is available on the EFIC website. So in terms of our online educational activities, I suppose our flagship educational program is the EFIC Academy, and this brings together everyone who wishes to advance their competencies in the Federation's comprehensive multi-professional education program. So I suppose the flagship initiative in the Academy is our, individual membership of the Academy allows you access to our educational projects, for example, the Summit, our educational platform, reduced fees if you want to sit the diploma examination, free access to EFIC's Pain Journal, the European Journal of Pain, and of course access to webinars. So this is an individual membership. However, EFIC does welcome collaborating with universities and hospitals, where a group rate is also available. So again, if you're interested, please contact us at EFIC. So the jewel in the crown of the Academy is our education platform. Platform was developed in consultation with medical educational specialists to ensure, I suppose, effective and appropriate pedagogy. Again, it's developed around the 4 curricula. This is just a screenshot of the platform. So if you're looking for information around low back pain management, you can search under the physiotherapy curriculum, but it will also bring up how low back pain is assessed and managed from a medical perspective and for psychological perspective in particular. So as well as discipline-specific learning, you have an opportunity to expand your knowledge on how other healthcare professionals manage such what can be a complex and disabling problem. So again, this is just a screenshot doing a bit of a deep dive into the platform. So this on the right-hand side, you can see we have the table of contents. So this summarizes the EFIC curriculum. And then under each topic, each subsection has has 3 or 4 brief educational sessions that are recorded. So for example, I've just highlighted here, Professor Chris Main recorded I had a conversation with him, which we recorded, on how to make psychology more appropriate to the patient and the public. So, of course, this is something that's terribly relevant for managing back pain. In the years where we don't offer an EFIC Congress, we hold a 2-day virtual pain education summit. Again, there's over 30 hours of teaching across the 2 days, and all content that we build or that we produce for the summit is then embedded into the education platform. So we're constantly updating the sessions that we have on the curriculum to make sure that the full curriculum is populated. So of course, at each conference, back pain is a common topic as part of the education summit. There are, again, discipline-specific sessions as part of the summit, but we also then importantly have interprofessional sessions, and it's live and the audience can interact with the speakers. In-person education activities, EFIC has developed and run a number of pain schools. These usually run on a biannual basis. So we have cancer pain schools, we have a translational pain school, we had a musculoskeletal pain school in Denmark in 2023. In 2024, we have a translational research pain school that has happened. But I do draw your attention to our new pain school, Psychology for Non-Psychologists, that will be held in the beautiful city of Verona in Italy in November. With the pain schools, these are interactive teaching courses taking place over from 2 to 4 days. And they're targeted at healthcare professionals interested in, I suppose, in further developing their knowledge and expertise in a specific area in pain management. They're led by some of the most distinguished and talented educators from across Europe. And we deliberately keep the pain schools small so that the sessions can be interactive and engaging. For each pain school, EFIC offers 15 scholarships to attend the pain school, and these will be advertised through the EFIC communication channels, our newsletter, on our social media campaigns, but also on the EFIC website. So if you are interested in applying for a scholarship, please do contact us. Scholarships have been awarded for the pain school in Verona. However, there is an opportunity for a small number of multidisciplinary healthcare professionals to pay to attend the school. So if you are interested, please, again, you'll find more details on the website. In terms of EFIC's research pillar has a number of key activities. During my term as president, I initiated the development of an EFIC research strategy, and I've linked this with Luis Garcia Larrea, who is the current president, and we currently have we finalised the strategy, and it's under review for publication in the European Journal of Pain. So, of course, back pain research, of course, we heard from previous speakers, it's a lot of research that has already been done on back pain, but there's more that needs to be doing. And again, this is outlined in our research strategy paper. EFIC is an active partner on EFIC on European level grants, and we're collaborating on Horizon 2020 grants, on Erasmus Plus grants, and other grants such as Innovative Medicines Initiative, IMI. So if you're considering submitting a European grant on back pain or any other pain-related topic, perhaps think of EFIC, and we'd be delighted to talk to you more. Our EFIC Pain Scientist Network, this is an internal register for researchers. So if you're undertaking research in back pain or any other related topic, we can put you in contact with other researchers who are interested in participating in research in similar fields, whether you're a senior or a junior researcher. Or if you're interested in getting involved in a research collaboration, we can also make internal links with other members of our community across Europe. EFIC provides grants and prizes. So again, we have an EEG grant with Grünenthal. So again, if you're considering conducting some research in back pain management, consider applying for our grant. Again, all the information is on the website. So this is just an example of some of our key activities that are ongoing. EFIC convenes independent experts from time to time to develop scientific position papers. So as you can see, we have the EFIC research strategy that will be hopefully be published shortly. We wrote an editorial last year for the European Journal of Pain, but we've also published clinical recommendations on the use, or more importantly, not using opioids for chronic non-cancer pain. And we've also one for the use of opioids in specific populations. Bart Morlion, who is an anaesthetist from Belgium and who was president from 2017 to 2020 at EFIC, created the idea of a president's campaign where each president could focus on a particular topic for the 3 years of his term. So I was delighted when Bart chose the topic of promoting physical activity to prevent and manage acute and chronic pain. And as Kieran mentioned earlier, we collaborated with the Europe region on this project. We developed a campaign material, so we have infographics, and we developed short videos for promoting physical activity for people living with pain, for healthcare professionals, and also promoting to the general public the importance, I suppose, of being physically active. These initiatives have been translated into 17 different languages. So again, please feel free to go on the website. They're free to download, and we encourage you to disseminate them as widely as possible. We've heard already from the speakers today the importance of physical activity and exercise in the management of low back pain. We've also just published in the European Journal a position paper on the importance of physical activity. Again, it's in the journal, but you can also find it on the EFIC website. The theme of my presidency was on focusing on health literacy. And as Kieran mentioned earlier, promoting key messages around pain is so important, to debunk the myths and to build resilience in our patients. So of course, if we want to do that, people need to understand what we're saying. So the Plain Talking campaign, again, similar to the On the Move campaign, we promoted infographics for strategies, excuse me, strategies that healthcare professionals can use to improve their communication techniques. We've developed an infographic again for patients, and also one for the general public, promoting the importance of clear communication. Again, we've developed videos. These have also been translated into multiple languages and are freely available to download. Also, which may be of use for people with back pain attending either physiotherapists or a doctor or GP or consultant with back pain. We developed a patient journey booklet, and this booklet, I suppose, walks people through the steps of what will happen when they go in for a consultation. People may not be aware that they need, to fill in questionnaires, helps them prepare for questions they may want to ask their healthcare professionals. So, we believe it's a useful tool in promoting health literacy and ensuring that patients can understand the information that healthcare professionals are giving to them about their pain and, of course, about their low back pain. So that's just a whistle-stop tour of resources that EFIC has to offer physiotherapists and other healthcare professionals. I just draw your attention to the EFIC Scientific Conference in Lyon in 2025. The theme of the conference is comorbidity of chronic pain and mental health disorders, breaking the cycle. So again, physiotherapists are core members of the team here, and we all know the benefits of and importance of exercise and mental health. If you're interested in submitting a workshop, there is a late breaking workshop call that is open until the 16th of October, and the Scientific Programme Committee have highlighted a number of themes that they're interested in receiving workshops from. So arthritis-related pain, speaks very clearly to back pain. So again, if you're interested in putting together a workshop, there's more information available on the website. So I'll close there, and I'd just like to thank the European region of World Physiotherapy for hosting this webinar, and on behalf of EFIC, I look forward to a long and fruitful partnership, and I'm happy to answer any questions your audience may have. Thank you very much.
Thanks very much, Brona. That's very interesting. Excuse me. So that brings us just to the time where we can do the questions and answers to the presenters. So I have a few questions have come in, and we have an old friend of yours, Kieran, who has helped us on many occasions. Pete Moore has come in with a few questions, and I think you've answered them in the chat box, but maybe we could just run through them for anybody who didn't see them in the chat box. Peter's interested, and I'll turn it around a little bit, and the question would be, are physiotherapy schools including learning supported modules on self-management of back pain within the curricula?
So I guess I typed in a response there in the chat, but I'll let some others come in. My sense, and it was a great question, Pete, is that there is a lot more talk about the importance of self-management in physio programs, at least. I can't speak to other disciplines. So there's lots more talk about the concept, the importance, and developing resources. However, and this is not blaming anyone, I think in reality, when it comes out to professional practice placements, people with persistent pain are well down the priority list. And so often there's long waiting lists, and when they're seen, there's limited time, long waiting lists, and the opportunity to adequately support them through self-management is severely lacking. And so I think that's where sometimes I think people with pain might be concerned that when we say self-management and we mean supported self-management, they might hear and experience abandonment in terms of, you're on your own there now, honey, off you go. And so I think, but I leave other people come in on that. I think it's something we still need a lot of work on.
So I suppose we could ask Phyllis, in your university programs, Phyllis, is there self-management modules around back pain for your students?
Actually, we do have some courses for undergraduate and postgraduate students. It's not a kind of module, but it's kind of courses included in the rehabilitation of the low back pain patients. Because, you know, self-management is the key factor of the rehabilitation, because education is another job of us, another profession of us. So to be a good educator and mentor for the patients is very important. That's why we are always recommending these strategy to our patients in both undergraduate or postgraduate courses of us. And then also they are seeing our strategy in our clinics, because we have clinics in our faculty. Then all of the students of us, especially the internship students, can have an opportunity to see the real patients, especially during their treatment, and our behavior to our patients. Because as a teacher, we are also doing clinical practice in our faculty with our assistant. That's why they may have a you know, impression about our behavior to patients, and also the educating of our patients in these clinics.
Okay, that's great. That's great. Thanks very much. So, Kieran, we have Matilda from Denmark, who is very interested in your comments about coaching. And she's interested in knowing about the definition of pain coaching and the pros and cons of it for physiotherapists. Maybe, would you like to comment on that?
Sure, I'll come in on this. And again, I know based on what we were just mentioning, Pete Moore is in the audience. He mightn't be able to speak on this, but I would recommend people check out his Pain Toolkit website, which is especially around pain coaching. I guess I'm not so much interested in the term coaching. It's something we do. Like, for example, we might describe it as something different in 10 years' time or in the past, like Felice mentioned, mentoring, supporting, advocating. But I guess it is a little bit of a mindset change from the stereotype of people going to see manual therapists like ourselves, where it's come in, get fixed through some form of adjustment or treatment or machine, to actually saying, well, some of those things will stay as part of the toolbox, but really what we want is to get them on top of that. And so whether it was around, again, consistent with that idea of supporting self-management, I don't know what we call it or almost how formal we want to make it. We might call it different things, but essentially, to use an analogy Pete and others describe, putting the person in the driving seat. So we might help them at the start, give them some hints, some nudges, some tips, but as much as possible, they take over the journey and take over the control of that. And in that, I suppose that's where I'm coming from with that coaching mindset and those trials that Esther Mary talked about at the start, the Restore trial, led by Peter Kent and Mark Hancock, and then Mark Hancock's more recent trial looking at walking. They did involve things that would be very much like traditional physiotherapy, clinical assessments, exercise, but there was also behavior change. And I know there's other questions related to it. It wasn't a short, intense burst of treatment. So for example, most coaching interventions talk about seeing people a little bit, but for a period of time to allow behavior change bed in. So what we're talking about here doesn't fit in with seeing people 3 times a week for 3 or 4 weeks, but more starting, tweaking, adjusting, figuring things out. And again, I'm sure others will have some thoughts.
I would agree exactly, Kieran. And I think now it's all about, you know, there are so many, you know, chronic diseases, you know, that it's not just for back pain. We're teaching this approach, you know, with cardiac disease, pulmonary rehab, you know, so it is something that we are embedding. It is embedded in our curricula, you know, because we're seeing it not only in musculoskeletal therapy, but this idea of supportive self-management must go across all the, you know, the neurological and the cardiovascular diseases that we assess and manage.
Would you like to come in there, Esther Mary? I see you nodding your head furiously.
Thank you. Yes, I mean, just to really endorse both what Kieran and Brona have said, it's that idea about, I suppose, supporting not only through the management, but through the change behavior process, and just, you know, empowering people to manage and be in the driving seat. And it goes across all of the work that we do. It's not restricted to low back pain. So it's almost a module in itself in terms of how we deal with all our patients in those who need to manage their own condition.
Thank you. Yes, very excellent. Okay, so moving on. Now, this is something that I think comes up a little bit, and it's probably just about language. So the question is about manipulation. And because there's the least evidence for manipulation, it falls into that category. I think it was Phyllis mentioned manipulation as part of the therapy or the manual therapy program. Okay, so maybe Phyllis, if you like to differentiate between maybe manual therapy and manipulation, or where you see that line, please.
Actually, many of the systematic reviews and meta-analyses, especially the recent ones, state that both manipulation and mobilization have the moderate level evidence. Actually, some doctors may prefer to manipulation, especially having quick response in the first term. That's why the participants may asking why the doctors preferring manipulation instead of using mobilization. These manipulation or mobilization program or other kinds of fascial therapy or neural therapy, neuromobilization therapy can be designed dependent upon the patient situation and also the characteristic of the pain. I mean, nociceptive pain, neuropathic pain, or the sometimes it can be designed dependent upon the physiological response of the patients. That's why many of the times I prefer to change my manual therapy programming dependent upon the response. And then also the situation of the pathology, because sometimes there wouldn't be just only one pathology, bulging disc or mechanical problems associated other muscle weakness. That's why one cases could include different types of problems. Dependent upon all those situations, we can have some choices, and these choices should not be keep on all the 10 sessions or many sessions. Maybe change in every session dependent upon the patient's response. But I know because of the chiropractic, especially the chiropractor doctors prefer to use manual therapy because quick response and also very quick time. The other techniques may need it more time. That's why some doctors prefer to have manipulation instead of other kinds of manual therapy techniques.
Thank you, Phyllis. And our next question really rolls into some of that. And Kieran, it's for you. It's regarding neuropathic and nociceptive pain. And the question is, should we exclude manual therapy for patients with chronic low back pain?
No, not at all. Actually, recently, we can talk about also nociplastic pain in patients with low back pain. Actually, firstly, it's termed for the patients who is suffering from fibrositis or other kinds of muscle pain. But nowadays, we can also mention about the nociplastic pain. Yes, there is a plasticity in cortical level in these patients in the chronic stage. But as far as I know, my clinics and also from the study results in the literature, manual therapy also gives some kinds of facilitation for the neural pathways. So that's why I use also chronic low back pain patients. I use manual therapy for chronic low back patients, and also the study results mentioning about should be used or can be used manual therapy for chronic low back patients.
Thank you, Phyllis. And I think, Kieran, I've heard you mention you've sort of an approach to that as well for chronic low back pain. Where do you sit on that?
Yeah, sure. So I suppose to preface my remarks on this, it's funny when you look at all the guidelines across the different countries from different professions, most of the things they recommend are very clear cut. They will all pretty much say, don't rush for imaging, opioids, surgery, don't promote bed rest, and maybe do focus on, like from our point of view, education, exercise. And then there's this small pool of interventions that sometimes, depending on the professional bias of people or how maybe they interpret the evidence, can be recommended in one guideline and not in another. And that's where manual therapy / manipulation fits, that it is recommended in some guidelines and not others. And in terms of the broad evidence, and of course, every patient isn't the same, there's evidence that it can, on average, be of benefit. The caveat often being that we're not sure how much for how long, because at the end of the day, if we're going to self-manage, they don't, hopefully over time, need too much physio intervention. So from my perspective, I would say that there's still, if I divide it artificially into assessment and treatment, there is still huge value in the touch element of interacting with a patient and the validity of examining somebody's person. Now, when you look at the evidence of what people want and value in an examination, they want to be examined, and this is the word they use, properly. Now, what that actually looks like, I don't know, but my instinct is that means the person looked at me, spent some time at me, did some tests, which we might think aren't that valid, but I think there's a strong role in the manual therapy assessment of that. I know for myself, I think I've handled that poorly in the past then, where I thought I felt something and said some scary things that might have added to the person's disability. But I'd be strongly in favor of assessing the person in a way that is fitting, is in line with their expectations. On the treatment part of how much of that treatment on an ongoing basis should be manual therapy, I personally think it probably should be a lot less than I have traditionally practiced, and then maybe we have. But if in the short term you have a patient who has benefited from this before and who you can use this as a way to get them on board, I don't have a black and white position on it. So there's definitely an element of fence sitting there.
Thanks very much, Kieran.
Brona, maybe?
Yeah, I was thinking there, Brona.
Yeah, no, I would agree, Kieran, and I'm just thinking of the Lancet series of papers that came out a few years ago, where they, I agree with you, different guidelines say different things, but they brought together a number of guidelines and looked at commonalities, and I agree with both you and Phyllis, where it can be used as an, I thought it was they call it a second strand adjunct, which I think is they have things that are first strand, obviously exercise, education, self-management, and then it's time limited adjunct. So I don't think you're sitting on the fence. I think that's what the guidelines are saying.
Lovely, thank you very much. Now, Pete Moore is asking us about meaningful movement rather than exercise. Now, Brona, I was going to ask you that. Do physiotherapists around the EU use this as a term, do you think, or not?
So I have heard the term. I'm not sure how, I don't know how common it is. I think with anything, with any exercise, physical activity, I think it's come back to what Kieran said, what's meaningful for the patient, so what is the patient likely to do? Is it exercise, or is it physical activity? Is it gardening? Is it, it can be walking, running, swimming, but it might be gardening. It might be lower levels of physical activity, but that, that may have more social aspect to it, that are important, for engaging the patient. So I'm not particularly, I don't know how widespread it is, but I think it's all around, like for all of us, doing a physical activity or an exercise we enjoy.
Yeah, great. Thank you very much. And Brona, the question came in there, I think from the Africa region, about support for membership for students from Africa. Does EFIC include Africa or not?
The EFIC Academy is open to anybody.
Okay.
Anyone can have access to it. There is a sliding scale for the different professions, and the lowest rate for a student rate is €35 per year.
Okay, great. Thank you. And Peter's come in again, and I suppose this is a management strategy question, really. I don't think it's so much veered towards ourselves, but we can always feed into it. And it's regarding the time given to appointments. Okay. I think he's relating to the NHS, that the appointment times are short, and sometimes the treatments that we're giving, especially if we're coaching patients or going through things gradually with them, that requires longer time to do that. But the long-term outcome is important and can be better. So how can we influence the times given to appointments and try to make them longer? Does anybody have any bright ideas on that? You influencers? Maybe Esther Mary, you've been all around Europe. Have you seen anything that works?
I don't think I can be included in the category of influencers today, and I really should leave these to the experts. But I do have a real strong belief in the importance of that very first appointment with our patients, and really listening, and as Kieran often says, indeed, listening to their story and what the impact of their pain is having for them and how we work it out. And I think, if we actually reduce treatment times in the succeeding treatment times and actually put the effort into the assessment, putting that patient in the driving seat, guiding them through it, and actually having a longer supporting time when they are managing, in the knowledge that they can come back if they need a little tweaking of their program or a little support, because of perhaps the pain has been grand, but there's been a little kind of return of it. So I think that we need to actually convince healthcare providers, and it may be the physiotherapist manager, or it may be a bigger part in the hospital or in the clinic, to allow that reorientation of the time allocation that we give to our patients to facilitate a better outcome. Thank you for letting me join that one.
Yeah.
If I could just add on to that, I would 100% agree. I guess it's when I do some workshops with clinicians talking about maybe some of these approaches, the single most common complaint, and it's a perfectly legitimate complaint, is what I'm proposing would involve spending more time and their system and structure doesn't support it. And so I can empathize with that. And obviously systems we're talking about here will vary, public, private, and between countries. But I do think if we look at, we'll say, promising interventions which have been tested in one country or setting and that maybe haven't worked in another setting, it's often not about the individual clinician doing something wrong, but their system and structure not supporting it. So taking something from a public healthcare system to a private healthcare system is often challenged because the funding models are different. And so I think it's almost like one of those things that you have to look at the healthcare system as a whole. I would argue in some of the systems, I would maybe, for example, look at the United States healthcare system and all its complexities, where you are probably rewarded for being very busy and doing lots of stuff, as opposed to the outcomes of the patients and a whole series of other things. So I don't think anybody's got it figured out. I know Gay and I live in a similar part of the world, and there's these challenges around time and waiting lists that exist. But we probably just need to go back to Brona's point about looking at the commonalities in chronic conditions. We've got familiar with the idea that COPD and falls prevention and diabetes require time and interaction over a period of time, but that only works if your KPI is not clearing a waiting list or discharging someone off the waiting list.
Lovely. Thank you very much. Now, Phyllis, I see your hand is up there. Did you want to come in there?
Yeah, actually, national health systems and insurance companies do not want to pay for it for longer duration of the physical therapy session, but we can raise some kind of suggestion to our system. For example, giving the 5 session or 4 session once in a week with a shorter period. We can give longer periods once in a week or every 2 weeks. That's why, because to be involved in these patients for a longer period in the same session is much more valuable than having a frequent session with a shorter period during 1 week. That's why I follow my patients once in a week, but longer period. Maybe can be much more helpful for the national system or insurance companies. Thank you.
Thank you very much. Now, we've come to the end of all our questions and we've given our answers. So I think we're coming to the end of our webinar this morning. So I'd like to thank all our speakers very, very much for preparing their presentations and delivering them so nicely and well. They've all been very interesting and very stimulating. I'd like to thank Miguel and the European region for organizing this webinar, and it's very useful for everybody. And finally, I'd like to wish you all a very happy World Physiotherapy Day, and thank you for your attendance.
Thank you.
Thank you very much.